Okay, so we're at the second part of assemble and troubleshoot equipment on the respiratory therapy exam. So we have this is 2A, section 2A. So if we, this chapter is really, really long, so I know you had quite a bit of homework in that. So let me get where we're at. So common problems with entity and patient interfaces, we know that nasal mask, it kind of tends to have a lot of leakage. And you need to use that chin strap. Sometimes it's really the discomfort. Refit, adjust strap, tension, change mask. If you're going to have to use that chin strap, why would you even need to have that nasal mask? You might as well go for the full face mask. You can get bridges, redness, pressure sores because they want to keep getting it tighter and tighter and so forth. Um, uh, Oral nasal, you're rebreathing, the same thing. Your use of non-rebreathing plateau exhalation valve, and impedes your speech, eating, so forth. Um, sorry, I'm trying to. Um, and claustrophobia, a lot of people get claustrophobia from this. And then you can also get aspiration risk. So if you happen to throw up in the middle of the night or anything like that, or you get sick, it can actually cause a lot of issues. Nasal pillows, you have mouth leakage. Use the chin strap as well. External nares, redness, pressure sores. Once again, you have your oral devices such as dry mouth, throat, lips. They provide supplemental humidification. You can apply oral lubricant, saliva replacement. You have numb lips, extended distance between the lips and the flange. That gum discomfort, you could try a smaller seal. The device falls out at night. These are the ones that you could bite down on, use. You have a nasal leak, or jaw, so forth. Mm. And you can make you really have excess salivation because you're using temporary resolves after initial use. Sure, it keeps going back to that. So I went backwards. Sorry. So our objectives. Okay, this one's going to have 15 questions, which are going to recall, 8 application, 3 analysis. You're going to intubation equipment. So we're going to be looking at our intubation equipment. Lost the page. Okay. Equipment obviously needed for a routine intubation. This means it's going to be the same one that's just routine, nothing out of the ordinary. You're going to need your personal protective equipment, obviously gloves, gowns, mask, eyewear. That's what the CDC wants you to have. You're not always going to need eyewear, if it's a bad intubation, such as, you need blood, there's blood or whatever. So then towels for positioning, not poisoning, positioning, because you might need to do a sniff, BVM resuscitator with O2 flow meter and connecting tube, suction apparatus such as a vacuum source, flexible suction catheters, and Yonker tube, and local anesthetic spray, laryngoscope handles with assorted blades, batteries, and bulbs, and water-soluble lubricating gel, endotracheal tubes, at least 3 different age-appropriate sizes. You got to have that stylet, the medullary forceps if we're going to do a nasal intubation, okay? So that's nasal pharyngeal intubation. A syringe for what? Our pilot balloon, our CO2 detector, for good waveform capnograph. Okay, so CO2 detector is good. waveform capnograph is our best solution. So if you get that question, that's the best. So tape and or ET tube holders or pharyngeal airways or bite blocks if needed. Additional equipment could be a tracheal tube introducer, such as a bougie, lighted stylet. Also, a bougie could be used for what? A trach tube changer. A lighted stylet, you could use that. Intubated laryngeal mask, a fast track. An optical video assisted laryngoscope, a fiber optic bronchoscope, or supraglottic airway, such as an LMA or a King airway. You also have accessory equipment needed for endotracheal airway, such as, you have your laryngoscope and blades. You can choose from the Mac or Miller. That's going to be depending on the preference. It's usually the doctor or you if you're the one that is actually doing that. To troubleshoot that, you need to really look at the bulb. If the bulb does not light, you need to check the handle, place the connection. Is it the battery? Is the bulbs? Style it. It adds rigidity and maintains the shape of the ET tube during insertion. Used only for oral intubation. Some video laryngoscopes are special proprietaries for the stylet. To prevent that trauma, you want to make sure that stylet tip does not extend that ET tube. It can actually cause more damage, and it can actually could potentially cause some type of pneumo. Tracheal tube introduces the bougie. It's bendable. It's a plastic stylet with that small hockey stick angle. Some tops have a central channel for ventilation and oxygenation. It's very stiff, so it could cause damage to the pharynx and the vocal cords. And for intubation, it's not a tube exchanger, although we say it is. It's used standard for tube exchanger instead. So like it says, troubleshooting for intubation, not tube exchange. Then in parentheses, it says used standard tube exchanger instead, because they know everybody uses it. Okay, so most people might not have one. So light wand, it's a flexible stylet with a lighted bulb at the tip, passed with an ET tube. It's a characteristic of glow jack-o'-lantern effect. So under the skin indicated tracheal placement. So no globe if the tube is in the esophagus. It does not confirm proper tracheal position, but it always checks breath sounds and confirm with the X-ray. Once again, your Magill forceps, they're used to manipulate the ET tube during nasal intubation by direct visualization. Once the tip of the ET tube is in the oropharynx, insert the laryngoscope and visualize the glottis, then use the forceps to grasp the tube just above the cuff and direct it into the cords. And to prevent trauma, never use forceps without a direct visualization and avoid forceful movement. Your colorectomic CO2 detector, that's disposable. It's going to confirm ET tube placement in the airway. It selects correct type based on patient size and weight. It's between the ET tube and the bag, and its tube position and lungs indicated when the color changed from purple to tan or yellow, and as the patient is ventilated at least 6 breaths. If it fails to change color, then you know that position during the cardiac arrest is a false negative. The color change can occur with improper placement in the main stem. So capnograph monitor provides numerical Petco display as a waveform, confirms placement. If you get condensation or secretions in it, it will affect the accuracy, and you consider a different confirmation device if the secrets are excessive. Ensure if the sensor is placed on the ET tube, placing further away can affect the accuracy. You got the bite block or the tube holder. Stabilize oral ET tube, prevent biting on the tube, or minimizes movement, accidental extubation. Options include the oral airway taped at the ET tube or flange tube holder. Gagging response may require sedation. It can make oral care difficult. So artificial airways, we should know most of these, you guys. Don't see why we have to continue, but I want to make sure that we know exactly what we're talking about. So indications, for selection used in troubleshooting of selected airways. We want to prevent from obstructing the upper airway during mask ventilation. So that's why we would use an oropharyngeal airway, right? That would be an indication for comatose patients who develop upper airway occlusion. We could use it as bite blocks for intubated patients. We could use that for patients having seizure. They can get lockjaw. You might have to open them. You also could use it from them, keeping them from biting on their tongue. Generally not indicated for conscious patients. Make sure you're using that proper size. Measure from the corner of the mouth to the angle of the jaw. If too large, it may occlude trachea and cause gastric insufflation. If too small, it's not effective or may push the tongue back and occlude the airway. In proper positioning, airways should curve or over the extended pass of the base of the tongue. And troubleshooting, if airway obstructed due to the tongue, it's not relieved. So remove the airway and reinsert and check the size. So, and if the patient gags or retches, remove the device and maintain the airway and move on. Same thing for the NPA. You to prevent airway obstruction, seizures, minimize trauma associated with repeated suctioning, avoid in patients nasal or nasopharyngeal blockage, such as polyps, adenoid hypertrophy in children, and proper sizing for average size female is a number 6, number 24 French. Male is a number 7, which is a 28 French. And you see how they did that? They times it by 4. When lubricated, the airway should fit through the inferior meatus without a force. If too large, it can cause a mucosal trauma, gagging, vomiting, and gastric distension. Never cut an MPA as the cut edge is too sharp. Always insert the beveled side point towards the nasal septum. To prevent slippage in the nasal cavity, always use a flange or trumpet type of airway. If you cannot pass the airway, be sure the MPA is lubricated. Try the other nearest, try a small airway, and if suction catheter will not pass, you need to use that lubricant. Consider a larger airway or smaller suction catheter. So an endotracheal tube, shouldn't really have to go into that. We're 19 to 21 for females at our incisors, 21 to 23 for males. Always check tracheal insertion by breath sounds, plus a CO2 analysis to confirm the proper position with an x-ray. So we watch chest rise, we look at breath sounds, then we do either if we don't have a waveform, entitled CO2 waveform, then we're going to look at our colorimetric, and we're going to confirm proper position with an x-ray. Tube position, we always listen with breath sounds. So if breath sounds are not equally bilateral, we're going to deflate the cuff, withdraw 1 to 2 centimeters, and reinflate the cuff. Now, you're not going to pull any further back than that, because what you could do is pull the tube out. So if the breath sounds are not heard or the stomach distended, remove the tube, oxygenate, and reintubate. So if you do not hear them at all, this is what you're going to do. You are going to do this. If breath sounds are not heard or the stomach is distended, remember you're going to choose this choice. Okay? You're going to, the stomach is distended, remove the tube, oxygenate, and reintubate. And make sure you do not withdraw more than 1 to 2, or you're going to have to reintubate, okay? Leaks, if a large leak occurs, you're going to reinflate the cuff, recheck the leak. If the leak persists, check that pilot balloon, inflate the line, and valve for leaks. Bypass by inserting a small gauge needle with a 3-way stopcock into the pilot line. If the inflation line system is leak-free, the cuff is likely blown and reintubate, okay? So obstruction, follow the obstruction algorithm that we're going to talk about in chapter 15. We're doing subglottic suction, for VAP. We don't want the low-level suction to be more than 20 to 30, and it should be flushed with air periodically to maintain patency. The LMAs we really don't have to talk a whole lot about because it's not really going to be a big thing. You just need to know what it's for and so forth. Esophageal tracheal combination tube, same thing. If you can't ventilate through either connector, the tube may be inserted too far. Pharyngeal cuff can be obstructed in the glottis. To rectify, withdraw 2 to 3 centimeters at a time while ventilating until breath sounds are heard over the lungs. So, this one's going to have one in the esophageal side, and this one's going to have in the tracheal side. Okay, so it's a combination tube. So make sure you remember that this one just has one in is ventilating, and one's going to be in the stomach as well. So tracheostomy tubes, proper sizing is critical. That'll be in chapter 9. We've maybe touched on a little bit. It's for long-term positive pressure ventilation. Inflate the cuff to confirm integrity before intubating. You always want to check that. Remember, we always check position the same way we're going to do with the ET tube. Make sure correct size spare inner cannula is kept by the bed. We always want to do that because if they end up pulling it out or we lose a cannula or anything, we want to make sure we can get it right back in. Leaks, if a large leak occurs, we inflate the cuff, recheck for leaks. Same thing that we would do if we had it's the same thing. Just same principle, except for the fact that you got to make sure that if they pull it out, you got to have one that put right back in. Indications for selection of trouble use in specialty tracheal airway devices. So to facilitate weaning is indication for a tracheostomy tube, and to support patients needing intermittent ventilation support, and to facilitate speech. So fenestrated tracheostomy tubes, these are for weaning. Okay, we've talked about this. The fenestrated is going to have the little holes down the bottom. The size the same as a regular tracheostomy tube. Outer cannula has fenestrated openings above the cuff. Remove of the inner cannula opens the fenestration. So plugging tube after cuff deflation allows normal upper airway function. So you can plug the tube by deflating the cuff. Remove the plug to suction. And to provide positive pressure or protect the lower airway, reinsert the inner cannula and reinflate the cuff. So you can take and put the inner cannula back in, it will reinflate the cuff, and now you can provide positive pressure ventilation back. Okay, so during the day, if you're getting ready to wean them, so you can go back and forth. They're not ready to be fully weaned, but we're weaning them maybe 8 hours a day till they're getting strong enough to go full on. Troubleshoot, never plug the tube with a cuff inflated. We've talked about this. Don't do that because it's going to suffocate them. If the respiratory stress occurs when the tube is plugged, make sure cuff is fully deflated. If a deflation of a cuff does not relieve distress, the tube may be improperly positioned, and carefully reposition this. So speaking tracheostomy tubes, those allow, the vocalize, and even when they're getting mechanical ventilation, patients not needing a cuff for airway protection. They're sized the same way as other trach tubes and include a separate small line that adds gas flow 4 to 6 liters per minute. And they have a Y connector that controls the flow, and the cuff must be inflated for vocalization. And leaks and obstructions are managed the same way, and separately label gas supply and cuff lines to avoid mix-up. So you have a trach button. We've talked about that. They're usually red, and they maintain an open stoma after tracheostomy tube removal, and it's to facilitate weaning from a trach tube, and it provides long-term suction of a lower airway. So you can take it off and you can suction it, and it consists of a short cannula flange at both ends, and exact insertion length controlled using spacers, and a cap seals the buttons and forces the patient to use the upper airway. So what it do is it's going to force you to use your upper airway instead of using your lower airway. So some buttons provide an adapter for positive pressure ventilation in case they get in a position where they get a mucus plug and they have to go back on ventilation or something else happens. Regularly pass the suction catheter through a button to ensure patency. So if you have to, you're going to troubleshoot it that way. If respiratory distress occurs, the tube may be protruding too far in the trachea, so you might want to reposition it and change the number of spacers. Now, we have speaking valves. We talk about those. They're called passing mirrors usually. They allow them to talk on the buttons, and they're contraindicated for unconscious patients or with HMEs, because HMEs would actually cause more dead space and keep them from talking. It's a one-way valve for inspiration through the tube, but blocks expiration. You got to make sure the cuff is fully deflated or they will suffocate. Always suction through the tube and above the cuff before attaching. You want to make sure they get all that stuff out, because it would feel, you don't want them to cough because they could blow it off or they could get secretions in it. If used with a ventilator, select the time or volume cycle mode and adjust alarms, because it's going to cause more pressure, because you can put it in with the circuit. If patient experiences distress with the valve and cuff dilated, likely causes are airway obstruction, secretion problems, or too large tracheostomy tube. You need to remove the valve immediately. Okay. It needs to be cleaned with soap and water. You're going to rinse it. You're going to air dry it. It should not be worn during sleep. Okay, because it causes obstruction. Suction equipment. They're for secretions, sputum, specimen, patency. It's always negative, or a vacuum source, a collection system. You need a suction device for removing secretions. The wall system is central piping, and to adjust negative pressure, it's attaches to the disc suction. Regulators can provide either continuous, intermittent, or continuous vacuum, and incorporates either a trap or float valve in the collection bottle canister. And before suction, always confirm that the canister is not full, because if the canister is full, it's going to obviously not allow for you to suction. Ensure that all tubing connections are taut, because any leaks will impair suction ability. To set the suction level, crimp or occlude the tubing, the canister, adjusting the volume control. Negative pressure should be set to the lowest level needed to readily remove the patient's secretions and flush them out of the tubing with sterile water. So, selecting suction devices. So, your scenario is you would have an oral cavity or nasal passage with a newborn. You would choose a bulb suction. We're always going to go with that first. Oral pharynx, choose a Yonker tip. Trachea, select standard suction catheter. Bronchus, right or left, we use a Cody directional tip catheter. Nasal route, select a standard suction catheter with MPA, meconium aspiration. We're going to use a meconium aspirator. Vent PEEP, use inline closed suction. Tracheal cuff leak top aspiration. Consider continuous supraglottic aspiration system. Sputum collection, use sputum collection Lucan's trap. What? Sorry. Um, Consider a continuous supraglottic aspiration system, sputum collection. So the Lucan's trap catheter size, you always need to times 2 and then go down to the next small size. Guidelines for initial negative pressure levels, adults is 12 to 15, and age 2. If you're using a portable suction, walls 100 to 150, which is technically 100 and 120. They keep saying this, but this is debatable still. I think it's because they're saying this probably because there are some children that are quite larger. So I would really like to go back to 8 to 100 for children, and then go on back down the way we had always planned it. Okay. Let me. Okay, so we need to look at our catheter adept, and also how to troubleshoot those, and recommendations. So, should be inserted only to just beyond the tip of the tracheal airway. Shallow suctioning, distance equal to the tube plus adapter length. You need to reduce hypoxemia, VAP risk, and long deep recruitment in mechanically ventilated patients. You need to use an inline, that's usually recommended. Oxygenate for about 30 to 60 seconds in pre and post procedure. Neonates increase FiO2 by 10% only, because we don't want to give them too much. And use oximeter to monitor high-risk patients. Limit vacuum application time to 15 seconds. So we want to get in and out and use the least vacuum pressure needed to remove secretions. To minimize trauma, you want to use the least pressure. Once again, use an MPA when you're doing NT suction. Reduce that VAP risk. Provide routine mouth care. Ensure proper cuff pressure. Consider continuous subglottic aspiration with a high-low evac. And collect sputum sample. Use a sputum collection Leukogen's trap. How do you troubleshoot suction? We know if we don't have any no vacuum pressure, that you're going to have obviously a obstruction. It's not turned on adequately. Inadequate vacuum. Check vacuum settings and so forth. The patient becomes hypoxemic or bradycardic during the procedure. You need to stop, oxygenate, and monitor always. So make sure you do that. Stop, oxygenate, and monitor. So your blood analyzers, once again. So this is always a big thing that we sometimes kind of miss. Your POCT analyzers, your analyzer does not turn on. Your batteries are discharged or dead. You need to confirm that the batteries are properly charged. Analyzer turns on but fails to display proper startup. Software startup boot error. You need to reboot it. Calibrate error message. Is there a problem with the sample calibrating solutions? Follow the error message guidance and report the findings. You get flag results. Results outside the analyzer's reportable ranges. Send the sample to the ABG lab for analysis. Results rejected based on quality control criteria. A problem with the sample calibrating solutions, sensors, or devices. Repeat the analysis using fresh sample and new cartridge if sample's integrity is not in question. Heliox delivery. So mixtures of helium and O2 can help decrease work of breathing in patients with large airway obstructions. So we know that those are going to be tanks of 100% helium, but require a blending system. We can't just give it all through helium. You're going to have an O2 source to fail in such systems. The patient could receive 100% helium and quickly suffer from anoxia. So for this reason, most centers use pre-mixed cylinders already, so they're going to be already set up. You have 3 combinations, and you have to know that equation. You need to know it. This is a simple one to remember on top of the other O2 ones. So you'll be at 80-20, 70-30, 60-40. To ensure patient safety, always use helium combined with at least 20%, okay? At least. So if the gas mixture is delivered by flow meter, you must either use device calibrated for specified helium percent or apply correction factor. So your correction factors are going to be they're going to be right here. Okay? All right, 1.8 for 80-20, 1.6 for 70-30, and 1.4 for 60-40, okay? So for example, for every 10 liters of indicated flow on an O2 flow meter delivering 80%, you have an 80-20 mixture. The actual helium flow is 18 liters per minute. So 10 times 1.8 is 18 liters per minute. So you're going to have to run it at 18 liters per minute to get the adequate flow that you need. Oops, let me go back. For spontaneous bleeding patients, Heliox generally is delivered via a tight-fitting non-rebreathing mask. You're usually going to pick that NRB. That's going to be your best bet. Alternatively, you can deliver Heliox using a high-flow cannula. You can, if that's the only other option you have. It also can be delivered mechanically ventilated, obviously, those with cuff artificial airways, and via non-invasive route. All patients receiving Heliox mixtures should be closely monitored with an O2 analyzer with active alarms. It should always be used to continuously measure the FiO2 of the mixture provided to the patients. PFTs, you have mechanical respirometers. such as the RITES or the House scale. Remember the RITES? That's the black one that we've talked about quite a few times. Their RITES has always got the vein. So when we're talking about a RITES, you're going to have a rotating vein. You're going to measure gas volume via rotating vein with a gear mechanism. These rotations into the movement of indicators, hands, or a watch-like dial, and an on and off switch unlocks and locks the gear mechanism, and a reset button resets the indicator hands. The devices are unidirectional and always being from device inlet to outlet. So mechanical respirometers generally are accurate to within 2% of the recommended flow range. And these can be diminished by flows outside the recommended range, so they should never be used to measure force flows or volumes. So when we're looking at this respirometer, this is a respirometer like we've talked about. Yet use it with a bacteria filter. Here's a one-way valve. Here is your pressures. Bed size, volume, measurements. So a one-way breathing valve, like I just said, you have inspiratory and expiratory volumes. You want to protect from contamination because it might be used on multiple patients. This is not just a one-time use. Here's the position to measure expiratory volumes with its inlet attached to the expiratory side of the breathing valve. To measure inspiratory volumes, you would reverse this position by connecting the filter and the respirometer's outlet to the inspiratory side of the valve. So you would go a different way, right? So patients, basic, basic equipment setup for ROTS, bedside volume measurements. The steps to use this to obtain expired volume measurements. You need to attach that device to the exhaled side of the one-way valve. You need to instruct them to do a desired maneuver. So we could do a slow vital capacity, a minute volume. You need to connect the patient to the one-way valve breathing port. Move the on and off switch to the on position during patient inhalation. Have the patient perform the desired maneuver and time for minute volume. When the maneuver is completed, move the on and off switch to the off position and record the desired measures. So you have minute ventilation, which is, tidal volume equals minute ventilation divided by your rate. If properly functioning, the device fails to operate. You should recheck the position of the on and off switch and make sure the respirometer is properly positioned with respect to the valve assembly. Okay, validity checks and corrective prompts for portable spirometers. You could have problems observed with having issues. So back extrapolated volume, so greater than 150 milliliters. Correct prompts would be, don't hesitate to your patient. Time to peak expiratory flow is greater than 120 milliseconds. So blast out faster. You want to be more excited, obviously. Forced expiratory volume is less than 6.0 seconds. And end of test volume is greater than 100 mils. You need to blow out longer and repeat the FEV6 values do not match within 150 mils. You need to take a deep breath. So more than 160 milliseconds for school-age children and adolescents. So how are we going to troubleshoot some of these problems? You need to, a problem Q would be falsely high or low volume or flow reading suspected. Cause could be device is out of calibration, incorrect temperature or pressure altitude input, flow sensor, device out of calibration. So you need to recalibrate. Incorrect temperature, you're going to recalibrate device, be sure that to ensure proper temperature. Flow sensor assembled incorrectly or damaged, so you're going to reassemble or replace the flow. Leak in the patient or spirometry system, so we have low readings. Correct leaks, use nose clips, ensure proper lip seal. It's always good to use nose clips because it helps the patient do a much better test. Teeth, lips, or tongue obstructing the mouthpiece, so you want to correct patient's technique. Falsely high or low percent normal computation suspected. Incorrect patient data entry. So that means that you might have put in their height, their gender, or their age wrong. So you need to verify that correct entry data. I've saw one of those questions before on the boards. Issue troubleshooting. You have indications and FEBC, recommendations. So you can look back through these for your ATS guidelines. So pleural drainage systems, we don't talk about that much, but we can hit on that. So systems remove free air and or fluid, so we know that that's going to be our chest tubes and something that has helped first. So our chest tubes, it's going to take out the pleural space, fluids from the pleural space, drain that for our chest tubes. Standard pleural drainage system has 3 key components. We have a one-way seal to prevent air from returning to the pleural space, a suction control for adjusting the negative pressure applied to the chest tube, a collection chamber for gathering fluid aspirated through the chest tube. Once the pleural drainage system is operating, you should monitor the fluid levels regularly to ensure proper function. If the water seal chamber level is less than 2 centimeters, you need to refill it. And if the control chamber level is less than the prescribed suction level, you need to refill that. And if a pleural fluid collection chamber fills, replace the unit with a new one. If you need to transfer the patient, make sure the system remains below the patient's chest level and do not clamp the chest tube. Because if you clamp the chest tube, what's going to happen? It's going to create pressure, right? This will maintain the water seal and prevent any air from getting into the pleural space. So, the traditional wet 3-chamber pleural drainage system. This is traditional. This is what you usually see. Okay, so you have your suction control. So you're going to see this. 2 suction regulator. You have your collection chamber. You have your water seal. There's a lot going on here, okay? And this 2 chest tube, okay? So this is where this goes to the actual suction regulator. So this is what's sucking, okay? So sucking, okay, right here. This is where we get our little water seal, and this goes to the chest tube. So here we're sucking, and this goes to the chest tube. Chest tube, and it's sucking it out. Does that make sense? Collection chamber. Steps to assemble a pleural drainage system for evacuation of the pleural air fluid. It's aseptic technique, so that means that it has to be sterile, right? The system below the patient's chest level, usually by hanging it on the bed frame, you'll see it hanging there. Most of the time you're going to see it on the floor, but on the floor, what's going to happen is you're going to kick it over. You got to fill the water seal chamber with sterile water to the desired level, usually, once again, 2 centimeters. Fill the suction control chamber with sterile water to the desired level, usually 20 centimeters. Make sure the vent is unobstructed. Connect the collection chamber tubing to the chest tube. Avoid kinks or loops. Connect the suction chamber tubing to the suction outlet. Apply negative pressure until bubbling appears in the suction control chamber, and ensure that the water seal chamber level arrives and falls with the patient breathing or ventilator cycle. So they're tidal breathing. So once the pleural drainage system is operating, you should monitor the fluid levels regularly to ensure proper functioning. So you need to look at those and watch the prescribed suction level. If there's no bubbling in the suction control chamber, this is going to be one of those quality assurance questions, quality control questions, that you will see or get. So you would want to review this right here. So not working. So if there's no bubbling, this is what you need to do, okay? All right, so if there's no bubbling in the suction chamber, check the suction control regulator to confirm that it is on. Check the suction chamber tubing for connections, leaks, or obstruction kinking. Correct any problems. Check the atmospheric vent to ensure that it is open and not obstructed. So those are the things that you would do on the boards that they asked you that. If there is continuous bubbling in the water seal chamber, there is a leak either at the patient or the drainage system. I've seen this type of question. The patient has a bronchopleural fistula and is receiving positive pressure. Some air leakage is normal. Otherwise, you may need to determine the source of the leak and correct it. You need to determine the source of the leak. Briefly pinch the tube near the insertion point in the patient. So you might have to hold on to that to see where our leak is at. If bubbling in the water seal stops, the leak is at the insertion point or in the patient. If not, the leak is between the patient and a collection system. This also is a question as well. So you need to determine, is it in the patient or is it in between with the chest tube into the system? If the water level in the water seal chamber does not fluctuate with breathing, the drainage system is obstructive. So we know that if it's not going with your breathing, something in the system is obstructed. So in some cases, you need to check the collection chamber tubing for kinks. You might have to milk the tubing connected to the chest tube by compressing and releasing it along the length toward the collection chamber. You need to do this really regularly because if not, you can have clots because there's blood coming through there. If milking the tubing fails to restore pressure fluctuations in that water seal chamber, you need to check that patient for signs of pneumothorax. Immediately notify that physician of the problem. So this is an immediate problem, okay? Non-invasive oximetry monitoring devices. I think we've talked about this enough. Okay, so all bronchoscopes require a separate light source. Modern light sources are computerized light emitting LED usually controlled via touchscreen. So typical setup, power down, troubleshoot instructions. You want to set up the light source for use. So you're going to turn the unit on, do a self-test. Most units go into a no light standby mode. Open the cable port latch. You're going to insert a clean, dry light cable into the cable port and clamp it into place. Pull gently on the light cable to test that it's securely seated in the cable port. Connect that bronchoscope to the opposite end of that light cable. Put the unit into the operating mode, and that activates it. So as needed, adjust the light output via the unit's bright controls. To power down that, you're going to put it in standby mode. Unlatch the light cable. Run the fan for at least 1 minute to cool and turn it off. So most common problems with a bronchoscope is no light output. How do you troubleshoot that? You're going to ensure that AC power cord is properly connected, turn it on, ensure that any fuses are intact and operating, ensure there's a light cable properly seated, check for and correct any error codes, check the cooling vents not obstructed. If a safety shutoff cannot be deactivated, return the unit for service. So what instruments are usually used with them? You have a brush, a biopsy forceps, aspiration needle, grasping forceps, basket and snare loop, and balloon catheter. We talked about this the other day, what you do with these. So how are you going to clean these bronchoscopes? Usually while at the bedside, you're really going to clean them, working channels for 20 seconds. You're going to avoid drying of organic material. You immediately transport the scope in a sealed contaminated equipment bag for processing. Mechanically clean all the ultrasonic technology, reusable accessory instruments, and send them for autoclaving. So these will be autoclaved. Remove all disposable parts, cap and seal all light electrical connectors, and place the scope in a cleaning basin. You're going to follow the manufacturer's protocol, perform a leak test on the scope, add enzymatic cleaner to the water, and soak the scope for 5 minutes. You're going to use that solution to wipe external surfaces with a wet gauze and flush the suction channels. Insert an appropriate size cleaning brush through the working channel and brush all ports until no more visible debris is being removed. Flush the channel again to remove all loosened material. Rinse all internal and external surfaces with water to prepare the scope for disinfecting. And post-processing, after proper immersion time, you're going to rinse the scope and its working channels with either a sterile or filtered tap water according to recommendations of the disinfecting supplier. Dry the working channel with 70% alcohol, purge with compressed air, remove the water lock caps from the scope, and hang it vertically in the storage cabinet without attaching any valve. Document the disinfection process.